Good afternoon. I want to welcome, I'm Steve Higgins, Director of the Vermont Center on Behavior and Health. And I want to welcome you, those of you who are in the audience and those of you who are remote to the March issue or March version of our monthly lecture series. And we are in for a good one today. So as you see here, we have Lara Coughlin with us, and she's going to be talking about bringing contingency management to scale, key steps for public health impact. So Lara is an associate professor of psychiatry and coordinator of the Michigan Innovation in Addiction Care through research and education at the University of Michigan. Lara has a great educational pedigree. She did her bachelor's degree at Davidson College, an outstanding liberal arts college, very good psychology department that I'm familiar with, and then did her doctoral training at Virginia Tech, which I'm also familiar with because there she was mentored by my dear friend, Warren Bickel. So excellent mentoring in science there. And then a postdoc in the University of Michigan's multidisciplinary alcohol training program, which I didn't know about, but that's clearly an outstanding program. So Lara is, without question, a rising star. And I think the rising part probably isn't needed anymore, but it's definitely a star in addiction science. And really doing gangbuster work. She, every measure I'm familiar with, she is just knocking a ball out of the park. She has gotten herself a very large PCORI grant that she's leading on smoking cessation in people who use menthol cigarettes, a challenging population. And by large, I mean 16 million. That is a large initial grant to be a PI on. But right now, currently, she's involved in one way or another with about 10 different federal grants, and then has a large number pending and some passed. And so she got her PhD in 2018. So in 8 years, she is just going gangbusters. Approximately 85 publications in peer-reviewed journals. So, that's an average of 10 publications per year. While she's writing all these grants and doing these other things, that's a tremendous rate. Already on a NIH, a standing member on an NIH studies section, which is a huge step in one's professional development as a researcher. She has a number of different roles at the University of Michigan and a wide variety. I don't know how she has the energy to really carry them all out. Very active in the VA system, which started while she was still a graduate student, where she did her internship as in a VA hospital, and has continued that work and has done really some innovative research in their large database, their large VA database, very creative database, and has done some innovative studies. The articles that she wrote on that work and her other work have appeared in high impact journals, American Journal of Psychiatry, Journal of the JAMA Psychiatry, Addiction, American Journal of Preventive Medicine. Those are really just high impact, outstanding journals. So by any standard that I'm familiar with, Lara is just knocking the ball out of the park career-wise. And so I'm really glad that she's taken the time to be with us today. And so join me in giving her a warm round of applause.
Thanks so much, Steve, and thanks to everyone who has been taking time out of their very busy days to really make this a special and wonderful visit so far. It has been such a treat to get to be here, and I'm excited to tell you about some of my CM work today, and also some work that sort of spans beyond my own work, but thinking about the direction of CM work as it goes forward. And I realize I'm talking about this in a room full of people who know a lot about the topic. So I am grateful, and please be kind with me. So to begin, I have no financial disclosures in this space. I do want to disclose that my worldview on the topic of addiction and other topics is shaped by my experiences and by those that I've never experienced. I have many implicit biases that I try to be aware of, and they impact how I interpret people's histories, interpret findings that we find in the research setting, and how I provide care as a clinical psychologist. So I want to just explicitly state that I am the product of many things, and this includes extensive privilege that I am granted as an educated, able-bodied, able-minded US citizen. And today we're going to talk about contingency management. So for the first half of this talk, I am going to focus on some health services work, some real-world implementation work, and some policy and practice work that's been going on in what I'll sort of coin as classical CM. And when I say classical CM, I'm talking about in-person CM delivered in addiction care settings. And then for the second half of the talk, if you can stick with me, because we're going to jump for the second half of the talk. And for that part, I'm going to talk about what we can think of as more the work in the interventional science space, developing different models and studying different models of contingency management to enhance scale. So we're going to start with that first one, which is when I think about contingency management, everyone here knows it. So I'm not going to give you a boilerplate definition of contingency management. I'm going to give you my two favorite. My first favorite is that contingency management is a peanut butter and jelly sandwich. And why I say that is because we've got two slices of bread. That's the target behavior and the reward. So we have money, but two slices of bread is not nearly a peanut butter and jelly sandwich and isn't delicious at all. What makes a peanut butter and jelly sandwich delicious is that peanut butter and jelly, which is the reinforcement when we put these together in a way that makes it peanut butter and jelly, or in this case, makes it contingency management. My other favorite definition of contingency management is that it is an approach to counterbalance the powerful effects of drug use by making recovery-oriented behaviors immediately rewarding for the individual. There is no doubt in my mind, and in anyone probably in this room's mind, that contingency management is a highly effective treatment. It is one of the most clearly and consistently endorsed work, and much of that work was founded here at UVM. Again, speaking to why it's so special to be here. So the challenge really is not if CM works. The challenge is how do we scale it such that it really moves the needle to have public health impact? And I'm going to try to talk about that. So this is going to be our first half of the talk today, is talking about some of the work that I and those I work with have done in the VA, and then talking about some real world state rollouts and some policy and practice wins. So as likely everyone here knows, the VA is our largest national healthcare system in this country. It serves veterans and those who have served our country. And in a really incredible and showing great foresight move, the VA, under the leadership of Don DeFilippis, led the first large-scale rollout of contingency management, which started in 2011, which I think is worth really noting that this was way ahead of all the state rollouts of contingency management. So in 2011, through sheer willpower, Dom and his team brought contingency management to VA. They used a prize-based 12-week model, and they funded it. I'll try to always talk about the funding streams when I talk about CM real-world rollouts, because they matter a lot for if you can get it off the ground and if you can sustain it. So VA's CM is funded through internal VA funds that they got approved federally. And they rolled out CM in over 100 VA facilities across the country, largely the VA medical centers, largely not the satellite, more rural clinics, because of pragmatic barriers. And VA's CM rollout has served over 7,000 veterans. That's a pretty conservative number there, because it's actually quite hard for us to track any veterans that received contingency management prior to 2018. And it largely is focused on stimulant use disorder, though they also have tried contingency management programs for tobacco cessation, for MOUD and alcohol medication retention, and for, it's not listed here, cannabis use. So my work in the VA stimulant space actually started before we did any contingency management work. So in this paper, we were just interested, we were working on this at this time when a lot of focus was on opioid and opioid overdoses, and we wanted to understand what was happening with stimulant uses nationally, looking across the VA. Now, it sort of goes without saying, but VA is special in that they have this centralized data space that Steve mentioned that they call the corporate data warehouse, where you can actually access the medical records of every veteran served through VA, which is very powerful. What's even more powerful is they've really built infrastructure to be able to link that to other outcomes, importantly for what I'm going to talk about today, meaning that they link to National Death Index records. So you can see not only what care a veteran has received over the course of their care, but also that outcome. So in this paper here, what we were looking at was stimulant-involved overdose deaths. And what you can see here is time on the x-axis and overdose rate on the y-axis, and that we were seeing increasing trends since then. This work has been shown in civilian community through CDC records as well. And what you see actually is that cocaine and opioid overdoses were the ones that were going up the most, which sort of fits with the overdose trends we were seeing. But maybe what's most interesting to me from this was that blue and orange line there. Those are reflecting people that died of stimulant-involved overdose with methamphetamine only or cocaine only on board, showing that it was not only folks related to opioid use that were dying related to stimulant-involved overdose death. So this got us thinking. We're seeing these rising rates of stimulant-involved death in VA. And from a care improvement model, what we wanted to understand was, is the VA in response to this actually providing stimulant use disorder care? Defined this pretty broadly, okay? So when I say stimulant use disorder care, I want to be clear, I'm not saying CM right now. I am saying you went to the VA or you called into the VA and you received treatment where the diagnosis of record was your stimulant use disorder diagnosis, which is a way that we can look at this from a health services side. And again, here it's sort of small, but what you're seeing is that time again on the x-axis and number of veterans with stimulant use disorder who were treated for stimulant use disorder on the y-axis. And that dotted line there is we live in the real world, and there was this national, international, worldwide pandemic. And so that's marking when the pandemic happens. This is an interrupted time series analysis. What we saw is that it sort of looks visually like stimulant use disorder care in VA nationally is increasing a bit going into the pandemic. It actually doesn't statistically hold that, but we see like at least it's holding fairly steady stimulant use disorder care. Pandemic happens and we see this giant drop in stimulant use disorder care. Not super surprising either. We pretty much saw this giant drop in all behavioral health care and honestly in much healthcare in general at the onset of the pandemic. What is concerning about this is that we actually see, as opposed to a recovery in stimulant use disorder care following the pandemic, we do see a continued decline in care. So this was concerning because it speaks to the fact that not only do we have this big interruption, this pandemic that happens, but also that we aren't seeing the recovery that we were seeing among other healthcare services that were being provided. We went on in another paper, maybe the same paper, to look at this a little bit more. We broke it out just because, I mean, everyone who was living through the pandemic knew that there was this huge shift to remote care. So we wanted to understand what was going on for stimulant use disorder care. What we saw here is that gray line, again, time on the x-axis, the gray line is showing in-person care. So that sort of reflects that giant drop we saw at the pandemic. What we see in the blue is video-based stimulant use disorder care, which we see sort of is non-existent going into the pandemic, and we see a little bit of an increase in. And we see this upshot in phone-based care, but then it actually dwindles off. And when we look at it all as a whole, we see that lack of recovery to pre-pandemic stimulant use disorder care across the VA health system. A really incredible assistant professor at UW and at the Puget Sound VA, Maddie Frost, collaborates with our group a fair bit. And she then led this paper that you can see on the other side, looking at folks who had opioid use disorder, who are receiving medication for opioid use disorder. And during this post-pandemic space, when there was a real push to move MOUD, to keep people on MOUD by moving to telehealth-based care, whether or not that was happening. And what she found, one of the takeaways of this paper, is that those with stimulant use disorder were the least likely to continue to receive care. So co-occurring stimulant use and opioid use disorder care, even compared to people with other substance use disorders co-occurring with opioid use disorder care, really pointing to this place where there's this particular gap in care among those with stimulant use disorder that appeared to be getting worse post-pandemic. So at this point, we turn to what is our first line treatment for stimulant use disorder care, which was CM. And of course, we had a CM rollout happening across this whole time span in VA. And so we decided to look at what the contingency management treatment was looking like in looking like in the VA during this time period, so from 2018 to 2022. Now, why we chose this time frame, because actually the pandemic is not always the best time frame to look at healthcare because there's this big event that happened. But why we did is that it was in 2018 that VA was able to implement a note template within their healthcare record that allows us to actually see every time a person receives contingency management. So while contingency management was happening in VA from 2018 to 2011, there are reports of it that largely Dom led. Those reports all have to be at the clinic level, about sort of provider reports that they treated X number of veterans with contingency management. It's only once that health note record comes into play that from a data perspective, we're able to link CM receipt to patient level factors. So noticing this, we decided to jump on it and to look at contingency management in the VA health system starting at that time. So here's just some of the initial things we found. For example, veterans receiving contingency management in VA, on average, were about 52 years old. Over half of them were in the past year unhoused or housing unstable, really speaking to that we are treating a complex patient population in VA, which I'll state is a really huge strength of CM in the VA, at least, is that this is not a treatment that is being given to the healthiest patients, which sometimes happens when we roll out empirically supported treatments. It ultimately ends up that for a variety of systemic reasons, those who are the least sick or the least complex receive the care. In VA, over half of those receiving CM were unhoused or housing unstable, and basically everyone, 97%, were diagnosed with more than one substance use disorder. I will note that in general, the veteran population is a complex medically population, so this kind of isn't necessarily surprising in that sense, but is actually a really strong testament to contingency management. We also had a chance for the first time to look at on the person level whether or not CM was being delivered sort of with some really rough metrics with fidelity. And that's what we're seeing down here is we looked at on average patients in the VA during this 4-year period who received contingency management, or on median, let's go with, we're receiving 8 sessions of CM. So this is a 24-session protocol. So about a third of it they're making. This sort of benchmarks with what we're seeing in other real world contingency management work, maybe a little on the low side. They also were in contingency management treatment for about 45 days. A full course of treatment is 90. This is a good one. We see that between CM visits, we have about 4 days. So really are sticking to this idea of about twice a week receiving contingency management in real world care. So again, this is not a research protocol. So these are real tests of CM and how it actually flies when we put it wild. And the vast majority of UDS samples were completed when there was a CM sample and were stimulant negative. I mentioned Maddie before. Dr. Frost here led a paper with our group to understand among veterans who were receiving contingency management, who was more likely to receive it and who wasn't. So she looked at those with stimulant use disorder between 2020 and 2022 served in VA facilities. And there's sort of 2 big takeaways, in my opinion, from this paper. The first one that is noteworthy to me is that veterans were more likely to receive CM if they had other substance use disorders and if they had other prior non-CM stimulant use disorder visits. So if they were already receiving treatment for stimulant use disorder, that made them more likely to then get enrolled in CM for stimulant use disorder. She also found some pieces that weren't so surprising. For example, veterans living in rural areas were less likely to receive contingency management, those with trauma history, and those who were more medically complex. These are longstanding challenges of bringing contingency management to have public health impact. Maybe to me, the most important finding from this paper is that across veterans with stimulant use disorder, in the VA, less than 2% were actually receiving contingency management. I see this as one of the greatest challenges that we face in the addiction field right now. We know that in the addiction field in general, we have a huge behavioral health treatment gap. Only in general, about 10% of people with a substance use disorder will ever receive treatment for their substance use disorder. But only 2% of people with stimulant use disorder across this national health system that is like our largest addiction provider in the country, receiving our first line treatment for stimulant use disorder really points to an area that we need to dedicate a ton of resources to resolving. All right, great job sticking with me so far. This is the last VA project I'm going to talk about here. So this one, was last year, we decided to take a bit of a dive on this and to look at if CM was associated, what the association was with mortality. So this is a question that's sort of been knocked around for quite a while. People have asked this about other addiction treatments. For example, when we give people buprenorphine, is that associated with reduced death? When we provide someone with this surgery, does that improve long-term outcomes? So we wanted to look at this with CM. So we started with the entire veteran population in VA who had a stimulant use disorder diagnosis, a new diagnosis in the past year between 2018 and 2020. And we got this big number, 100,000 plus people. And then we looked at those who received contingency management and those who didn't receive contingency management. And we did one-for-one matching, where we basically took the body of work that we'd done to date, looking at who's likely to receive CM, and also the body of work done by folks in this room about who's likely to do well with CM versus not. And we tried to match on those characteristics as best as we could. And I'm showing you them here in order to have two cohorts that were as comparable as possible when you're doing retrospective research. So this is not randomized research when you're doing retrospective cohort studies. So we end up with, I'll note some pieces that are maybe important. It's the VA. The vast majority of this cohort is male. Another piece is that almost half had past year mental health disorders. 3/4 had past year SUD treatment before they started CM, important for those in the CM side. And about 4 out of 10 had past year hospitalizations, which that's a really high number when you're looking at a cohort of people, even a cohort of people with substance use disorders. But we matched on those. And then in this table, I'm going to give you just the raw numbers of what we saw when we actually just looked descriptively at the death records for these two cohorts, each cohort having about 1,400 people in it. In the top, what you see is that those in the CM cohort, 27 people died in the year after they started CM. And in the matched control, which were matched on time and on all those characteristics, 46 died. When we look at this as a rate of death, we see almost double the rate of death in the matched control cohort than in the CM cohort. When we look at overdose deaths, this was not a primary outcome. This is a low base rate event. And this is a relatively modest sample to try to do a retrospective cohort study in. So we were looking at all-cause mortality. But when you look at overdose deaths, you see that 10 overdose deaths happened in the CM cohort and 15 in the matched control. There are challenges to this. You only know when you look at National Death Index data if it's an overdose based on the death record reporting, which varies county by county. So just as a note, like death records, like anything, are variable and there's uncertainty involved. And then we also looked at stimulant-involved overdose deaths, which there were documented to be 7 in the CM cohort and 12. We also looked at these data, pulling out anyone who in the death record noted they died of COVID-19, because this overlaid with COVID-19 and these numbers stay. So then we adjusted for covariates, including time-varying hospitalization, since we had a quite high rate of hospitalization in this population, and we have a 41% reduced risk of death among those in the contingency management cohort than those in the control cohort. And those with more complex underlying conditions. So we look at that with an Elixhauser comorbidity scale. We're more likely to die during this follow-up period, which again, sort of we would expect the more medically complex individuals. We also wanted to look at hospitalization, because hospitalization is something that matters when we think about contingency management scale up. In part, the reason it matters is because hospitalization is an adverse healthcare outcome that is extremely costly to our healthcare system. So it's something that oftentimes we want to avoid. And in this case, what we see is that in our CM cohort, we actually had higher rates of hospitalizations that are driven, as you can see here, they are driven by the psychiatric hospitalizations. This was interesting to us, and they really didn't differ largely, actually a little bit lower rates of hospitalizations among those for medical reasons and about the same for surgical reasons. So really this increase is driven by psychiatric. We wanted to understand this a little bit more, so we poked around as best we can. And a few things I can say is that, first off, this is definitely an area that we should look at more, because this is an interesting idea that those when in the acute period of receiving contingency management in the year following starting contingency management, that we may be detecting an increased rate of hospitalizations, which the best thing I can state from clinical experience is that when someone goes off of stimulants, there tends to be the psychiatric withdrawal symptoms associated with the sequelae of that tend to be associated with sort of acute risk, and that we do see some increased psychiatric risk, which could account for why, like basically part of the process of getting over a stimulant use disorder. Entering into recovery may be this escalation in acute risk that we need to be accounting for and thinking about. But this is something that I think will be really important to look at in other state rollouts of contingency management, where I know in many state demonstrations, an outcome of interest is emergency department visits, and then also taking that to look at hospitalization rates. But the biggest takeaway perhaps from this work is that we saw a change in the likelihood of death among those who received contingency management than those who didn't. And I have to state a couple things, because I think this is important when we think about stimulant use disorder treatment in general, that across this entire cohort, regardless if they received contingency management or not, we saw a really elevated risk of death. So greater than 80% risk of death compared to what is less than 4% VA-wide for veterans. And veterans have a higher mortality rate than non-veterans in general too. So we're seeing more than double the mortality rate among those with stimulant use disorder, which to me just really emphasizes a need that we need to be focusing on stimulant use disorder treatment and making sure that we're getting our frontline treatments to those with stimulant use disorder. Also important from a policy perspective, I'm going to take us back to some work that's over a decade old now by Mark La Rochelle, that is a really beautiful study that he did that really was foundational in moving forward medication for opioid use disorder to being really scaled up as much as it has in this country, which I think we can learn a lot from. And really the key thing to note here, I tried to highlight it because it's tiny when I pulled it from his table, but is among those who take methadone or those who are taking buprenorphine, he saw reductions in risk of death in the year following, all-cause mortality, so the exact same outcome that we use. Indeed, his outcome for buprenorphine of 0.63 is the same magnitude. We had 0.61 that we see for contingency management. So to the degree that this holds and is replicated, this is really powerful information to say that as we scale up contingency management, we can actually reduce mortality related to stimulant use disorder. Okay, so quickly, and Tyler's here in the room, and so there are folks in this room that are more familiar with this than me, but I'm going to say that in a talk about contingency management, it is critical to say that California has done what no other state had ever done in rolling out a large-scale contingency management program funded. I'll always say funded through a CMS 1115 waiver. They used a model that was created here by Dr. Higgins and did a 24-week contingency management program. It is still live. They have served over 13,000 people with stimulant use disorder. And this is an incredible proof of concept that contingency management can, with adequate resources, be brought to scale. But I don't want us to take my word for it. I'm going to show this video that the group at UCLA made of their program, that for those of you who have seen it, I apologize, but for those of you who can't, it makes me tear up every time.
I see a lot of despair, I see a lot of brokenness, and I see people that are lost.
I had lost all hope. That's why I let myself go so bad to addiction. I didn't care no more.
Due to the lifestyle I was living, I ended up losing my daughter.
Because when you're doing drugs, you don't really feel like you have anything. So everything's gone.
I had lost all 4 of my kids, my place, and my car.
Over the last few years, we've seen a dramatic increase in the numbers of stimulant-related deaths. And it's something that, really impacts just about every population in our state, whether it's rural or urban, it's impacting everyone.
Specifically within the stimulant space, there is not an FDA-approved medication.
Contingency management is really the best that we have in order to help someone to enter into treatment, enter into recovery.
Contingency management is a really simple and deceptively complicated intervention. The simple part is what we do is we find a target behavior. In the case of the California program, non-use of stimulants as evidenced by a urine drug test. And anytime someone shows that behavior, we give them an incentive.
And the incentives that we use for recovery incentives are gift cards to a variety of different vendors.
In doing that, we flip the script on urine drug testing, and instead of working to catch them being bad, we're working to catch them being good.
It's interesting in the science to kind of look at how the reward circuitry is being rewired and sort of creating different options for folks. And it instills sort of a path toward hope and renewal.
Getting the gift cards every week let me be able to do things with my daughter every week on our visits.
My source of income was completely cut off, and that helped me out a lot.
I buy my shoes, I buy clothes, beautiful stuff, like, you know what I mean? And it feels great to receive those things, you know? But I know further in life, like, my reward will be to stay clean.
The other thing is it's not just about those incentives. There's a relationship that happens between the CM provider and the client.
Being positive and supporting is critical in forming that relationship and making them understand that we really are here to help.
And you're not being demonized for your recovery or feeling super down about your recovery because you're going through a lot anyway.
We talk to them a lot when we come in, and they're all for trying to help us stay sober and give us the resources that we need. Because I mean, in my town, we don't really have that.
And after those successes begins to build up, the person feels stronger, the person feels more confident, the person begins to put more successes on top of itself, and there is powerful healing in that.
I never thought I would be where I am today when I was still using. I have prospects for careers. I have an excitement for life again. It's a complete turnaround.
I'm actually graduating in 2 weeks. I'm ecstatic to be getting my daughter back this month.
It's like I'm starting to go to school, and it's like, because they helped me through it. I never thought that that was really worth it. And to know now, it's like I actually love myself. So it's awesome.
The important part of a pilot program is to show meaningful results. And that's particularly important in a state like California, where we have an incredibly diverse population. We have incredibly diverse geographic territories.
I've been doing evaluations for about 25 years, and this is the most consistently positive that I've ever seen any results come back.
95% of Medi-Cal members that are participating in this program regularly test negative for stimulants.
We have over 117 clients enrolled right now that are testing clean, that are proving that this program works.
Everyone who is experiencing stimulant use disorder should have contingency management as a treatment available to them.
So if we can show that this is a treatment that works in California, then the rest of the nation hopefully can follow suit.
And every day I try to remind my staff, and I try to remind all the people who are implementing this program, that it doesn't matter whether you see it or not. Today you saved a life.
I thought that was really good. So California has really led this space, but many other states are doing really important work too. This work that I'm showing here, led by an undergraduate at Michigan, looked at those states that had applied for 1115 waivers that included CM within them. And you can see that there are a few states that have them approved, a few states that withdrew them. West Virginia is the only one I actually know of. And then at least Michigan has submitted one, but not come back yet. What they submit varies really widely, what sort of program, but this is one conduit that states have been approaching to fund wide-scale CM impact. And of course, there's other ways that states are funding this too. So I note this, that here in Vermont, you all have a CM demonstration going on, funded through opioid settlement funds that Rick Rawson and Tyler Rath run. You have a program, there's a program just north up in Maine, funded through foundation funds. And Michigan has a program that I'm very passionate about, that currently is funded through opioid settlement funds, and hopefully ultimately will have 1115 waiver backing. Also, lots of other programs that I'm not mentioning today, but it's a really exciting time when thinking about real-world rollouts of CM. And these are in the context of some recent incredible policy wins. So I keep saying that CM is the current standard of care for stimulant use disorder, and we can say that because the American Society of Addiction Medicine and American Academy of Addiction Psychiatry publish stimulant use disorder guidelines in 2024 that say that much, which is really powerful and helpful to make the case that this is really something that every SUD treatment clinic should have on hand, which is not the case. Also in early 2025, in large part to the advocacy of the CM policy group with, again, Tyler and Rick involved in that, SAMHSA came out with their advisory that changed the cap on SOAR and TOR funded CM programs from $75, which really is not effective, to $750, which is effective, which is a huge policy win to open the door for that. And it's sort of yet to be seen what comes of this, but in 2026, the One Big Beautiful Bill Act increased the threshold for an institution needing to provide a 1099 form through the IRS from $600 to $2,000, which for those that are watching all the state rollouts of CM and seeing that the vast majority of them cap incentives at $599, that's not a coincidence. And so this really, again, potential opening of doors. So to summarize, we are seeing we're in like early exciting days of CM scaling nationwide. Large scale programs, VA, California, are demonstrating that CM can be done on a big scale. And then some of these smaller states are showing both the challenges of doing smaller rollouts is actually very real. And like, how do you create a community of CM providers when you only have a handful of clinics involved compared to VA in California, where they have 100 clinics involved, right? We also are seeing like some recent really amazing policy wins, maybe more than I was expecting to see in that space. And this is a moment to celebrate and to grab that momentum and build CM out for policy, for public health impact. And this, I think, can stand on the first evidence to show that CM does save lives. However, I'm not just wearing rose-colored glasses here. There are some real challenges to stimulant use disorder, classical CM, having wide-scale sustainable impact. The first one that comes to mind for me is that one could conceptualize classical CM is potentially a high threshold treatment. We're only reaching about 2% of people with a stimulant use disorder, at least within the VA health system. That data has never been shown for any other group. So we really need to think about how do we make sure that CM is accessible to the vast majority of people with a stimulant use disorder, including those who live in rural areas who rarely have access to CM, even more rarely, and those who have other obligations that may prevent them from going into a clinic 2 times a week for months, which I really often ask people to reflect and think, could you do that? Because the vast majority of individuals cannot. We also do not have adequate implementation infrastructure. And I'm so grateful for those who call themselves implementation scientists and are going to solve this for us, because we really need to be able to know how to stand up CM in clinics, in health systems, and in states. Right now, it is largely done on a case-by-case basis. And those who are doing the hard work to synthesize what is working and what isn't working and how we need to standardize that, this is going to be so key if we are ever going to see contingency management across the majority of the US. And also, funding is a central and always has been a central challenge to contingency management work. It just does not look like what we think of as therapy, and it does not look like what we think of as medication. And so we have a treatment that just doesn't fit with our addiction care model. And so we need to think about what funding that looks like, because right now all the funding avenues that I discussed so far, 1115 waivers, opioid settlement funds, and foundation or grant funding, are time-limited funding infrastructure. So this is a big challenge. And in thinking about that funding infrastructure, we need to have equal attention to what guardrails, what we need to have in place, because oftentimes when a clinic hears about contingency management in Michigan and they come to us and they're like, we really want to do it, there's the funding challenge, but there is also how do we stand up contingency management that we know you're able to do it in a way that isn't going to open you up for financial risk. And I think a real risk here is we need to be making sure that folks know how to keep that audit trail, how to make sure that there isn't misuse of funds that could really actually hurt the CM initiative far more than help it. So there's some cautionary things here and a lot of work to do to have CM really make impact. But the really great news is CM works, CM saves lives, and we are living in a time where increasingly more clinics, health systems, and states are trying to adopt it. So with the rest of my time here today, I'm going to pivot and talk about one way that I think it is important to consider increasing scale for contingency management, which is through digital models of contingency management. So a lot of people in this room do mobile health work. So a lot of this will go without saying, but the real beauty of digital contingency management is the potential to alleviate that burden of people needing to go into a clinic multiple times a week to receive this effective treatment. And there's multiple ways that we can think about how we can improve it by doing that. But I think there's a lot of promise here. And I have for a little bit. So our team, we developed a platform that we call Incentives to Quit. Now, so everything I talked about so far has been in the stimulant use disorder space. Everything I talk about from here on out is going to be something else. A lot of it tobacco. So right now I'm going to focus on tobacco. So we had created a program that is built on some of the contingency management work done here and even digital contingency management work that's done by this group and others that we, and I'll say there's two sort of maybe unique touches to this. One is I'm a clinical psychologist and really wanted it to have sort of a motivational component beyond the contingency management space. So there's a lot of work been put into this to embed sort of a motivational enhancement aspect to it that I'll show you all. And the other being that we really developed this platform in partnership both with our state Department of Health, with our state Medicaid office, with lots of Medicaid beneficiaries, with the goal of this really reflecting what people wanted within our Michigan community. The reason for this is, unfortunately, Michigan falls within Tobacco Nation. We have high rates of smoking in Michigan, and it is both a real challenge for our healthcare system. It is expensive. It leads to morbidity and mortality. And also, it's something that just our tobacco control section is long for as far back as I know, just been incredibly underfunded to do the work that they really need to do, which is not unusual of tobacco control sections. But this is from last year. This is from Michigan. And what you can see here is tobacco smoking rates. So for those of you, and I know many are here that are tobacco researchers, you will know that these are quite high. What we see in Michigan is that those who are lower resourced and Medicaid beneficiaries have really quite high rates of smoking. And the goal of this work is to make a dent on that. And this work is not NIH funded. I think it's important. This is all going to be quality improvement work that I'm going to share with you here until I tell you we're back on the research side of the house, which means this work is funded through multiple sort of streams, a really important one being managed care organizations in Michigan and Michigan Department of Health, as well as a health fund, which is a philanthropy in Michigan, and our own health system at University of Michigan. So this really beautiful image was made by Dr. Devin Tomlinson, a T32 fellow that we're lucky to have at University of Michigan, and came out earlier this year. And for those of you that aren't used to looking at micro-randomized trial designs, I'm going to just walk through this quick. So this is actually the design that underscores the Incentives to Quit program. So what you see here is that folks, they are asked to, in the morning and the evening, to complete a breath sample and a check-in. A check-in is just a brief survey within the app. If they complete, I'll try to use my mouse here. If they complete the survey, if they complete it, yes, they get a little reward, I think 50 cents. If they don't get it. If they complete their breath test, they get 50 cents. If they don't get the reward. If they complete the breath test and it's smoke negative, they get the bigger reward here that you can see up here. And if they complete the breath test, they get the reward for completing the breath test, but not for having a smoke negative sample. Regardless of the outcomes of this, and regardless of if they even completed the breath test or the survey, they are randomized at a coin flip to either receive or not receive a motivational message. This is the micro-randomized component. And the micro-randomization is focused on two outcomes: whether people submitted the next check-in, whether they actually submitted it the next time if they received a message or didn't receive a message, and whether or not when they submitted it the next time it was smoke negative or it wasn't. And what this paper finds, if you go look at it, is that people receiving these motivational messages that we actually developed with community members across our team and are focused on enhancing motivation to make change to smoking. I'll talk a bit more about those in a moment. They were more likely to submit the next sample, about 7% more likely. They were more likely also, this was from our first pilot of this work, which was only about 30 people for context. They were also more likely to have smoke negative sample, but it wasn't statistically significant. So this is a busy slide, but I'm going to show it to you because it's really important for understanding the context of the Incentives to Quit program. And also you guys get to see my first try at using ChatGPT to make me an image. The Incentives to Quit program is not just an app, though oftentimes when we talk about it, it sort of sounds like that. A really important part is that you do a welcome call, which is this MI-based welcome call when you enroll in the program. It serves two key purposes, briefly. One of them is that it makes sure that you know how to use the app, that you know how to use the Smokealyzer, and that you understand sort of what's going to be happening, that you understand the CM schedule, that you understand how long this treatment's going to last, that you know how to enroll in the tobacco quit line, and actually we enroll you in the tobacco quit line. It also serves the purpose of understanding people's individual reasons for wanting to make change to their smoking, which then is fed back into the app through those messages that I've been talking about. So those messages are not just a bank of messages. Those messages are tailored in three ways. So first off, every message, whether you're randomized to receive a message or not receive a message, is tailored based on whether your sample was smoke negative, smoke positive, or not submitted. So you can see that right here, that if, for example, you don't submit a sample, you receive a different message, which you might be able to read, yeah, you can, than if it was smoke positive or smoke negative. Also, they're tailored on two other things. One is those reasons that you share with your coach during the welcome call that you want to quit. So some people might want to quit so that because it's inconvenient to have to take smoke breaks, or some people just want to quit in general. Some people want to quit because it's expensive or for their health. There's messages for all of that, and those are tailored to the individual. And then there's also identity management. There's identity features that we've built in. So LGBTQIA+, if you're pregnant, if you're a veteran, if you have a disability, all of these have been built in as identities that people can self-select. If you're African American or Black, there's several of them. And then so people can identify what identity features they want to be reflected in their app experience as well. In sort of classical CM fashion, they can receive money through the wallet, and they can pull it out at any time they want in the form of gift cards. And we also, because people are completing those surveys, and I just sort of have this belief that if we're collecting data from people, we should be feeding it back to them. We have this home dashboard where they can see how things are going for them. For the sake of time, I'm not going to show you the app, but I'm more than happy to. But I am going to show you something that I'm proud of, which is, again, this is a quality improvement project. And in the state of Michigan, we are serving people across the state, and increasingly expanding. This focuses on our perinatal program to promote smoking cessation. And I'm, again, going to save you from watching this video, but more than happy to share this. Our team of amazing coaches created this sort of demo to show you what this looks like. A really key piece that I never thought about when building an app was how important it is to have an awesome dashboard interface for your team to be able to do all of this, to make sure that those motives and identities and that people's submissions are going on, and to be able to do QA in real time, because apps break constantly. And so I'm really proud of this dashboard that we've put together. But we're not going to we're going to try not to listen to it before we. Okay. Also, I'll just emphasize this is quality improvement work that I'm talking about here. So a huge emphasis of this work is we spend a lot of time not just trying to provide the program, but trying to build up momentum and education in the state to make sure that people, whether those be policy briefs to legislatures and policy members, or newsletters to the clinics that partner with us, to make sure they are in the loop about how the program is going, who of their patients, if their patients are enrolling, what it looks like. We spend a lot of time on these relationships, because to us, this is the key part to this ever actually having wide scale impact, is making sure that clinics, that clinicians, that administrators, that policymakers are behind this program all the way. Okay, I'm going to take 3 more minutes here to go over this, because this is where the incentives to quit work moved into the research space. So in this, there's not a ton to say, but I co-lead this work with Erin Bonar, who's a professor at University of Michigan. And this is a large PCORI trial that is just starting. In fact, the clinical trial will be starting in May. Fingers crossed. So this is going to be looking at folks who smoke menthol cigarettes who call into quit lines. Now, I think maybe the best part of this project is this idea of we're trying to build on existing population health infrastructure. So quit lines exist across all 50 states. Even in this current place and time that we are living, there are still quit lines in almost every state. And they actually get, while not used nearly enough, a lot of calls. And so people who call quit lines who smoke menthol are getting the option to enroll in our trial, to either continue receiving their quit line services, they're randomized, or to receive the quit line plus the incentives to quit program, which we actually will be calling Wellcentive in this program. And here's just sort of a quick snap of it's very similar. This work also leans heavily on community engaged work. We have the most amazing multi-sector tobacco cessation advisory board, including managed care orgs, Department of Health folks from the American Lung Association and the North American Quit Line Consortium. And folks from both of the two major quit lines in our country. And it's just incredible how dedicated they are to this work, which is maybe only overshadowed by how dedicated our Lived Experience Advisory Board is. These folks are so passionate about ensuring that this work is impactful that it honestly inspires me on the regular to try to really put a lot of time and energy into it. And we just completed, because I don't really have much data from this given the clinical trial hasn't started, but we just completed a focused testing interview study with 28 people with lived experience of smoking menthol, where they looked at our app, they looked at those motivational messages, they helped us make it better, they helped us add features, they wanted to see new identity features. So what I was talking about, the people could indicate if they want to endorse the identity of being Black or African American or others. They wanted us to add identity features like relationship status, someone that's grieving a loss. So they actually really helped us to make our program better, which is incredible. And so this program otherwise is quite similar to what you can see as the Incentives to Quit program, which is in blue. They can receive up to $792 in incentives compared to the quit line only condition, which does not. We follow folks for a year. Have me back in 3 years and I'll tell you how it goes. Really don't have much more to say about that. Last thing I'm going to mention is this R34 that I lead with Ann Fernandez, who is a faculty member at University of Michigan for 3 more months and then is leaving us for Rutgers, which breaks my heart. But this has been a wonderful project to work together on, and we will continue working on it even with her at Rutgers. So this project is focused on keeping people on opioid agonist treatment, buprenorphine or methadone, as well as supporting them to reduce or stop drinking. It partners with Dynamic Care, which I believe many here are familiar with, and randomizes folks between contingency management or Dynamic Care's wellness condition. Sort of a theme you might see is we partner with clinics in Michigan. So these are SUD clinics in Michigan that are the direct referral sources for everyone that's in this program, with the one exception floating out there on a lake is Bicycle Health. They also partner on this, but for still their Medicaid beneficiaries in Michigan. This program is only for Medicaid beneficiaries because part of our outcomes is that through the state of Michigan, we will have access to, at the patient level, everybody's Medicaid claims data. So sort of similar to our work in VA, we'll be able to look at patient level utilization, both in the clinic level, SUD treatment, and in the hospital's ED visits. It's also in progress. So we started at the end of last year. I got this from Warren Bickel. Warren Bickel loved to look at recruitment graphs. So here's a recruitment graph a la Warren Bickel's lab. So what you can see here is we currently have 22 people enrolled in this. We are ahead of schedule, which I love to see. It adds years to my life. A challenge that we're having and that I didn't expect is that we have way more folks on methadone enrolling in our program than buprenorphine. I did not expect this. We're working on this, but we are really expecting actually to have the other situation. Just always come back to this, folks, is that a key part for our work to work is that we have this network of clinics that find value in working with us. And so a huge emphasis in what we spend research staff time on is lots of work providing information back to our clinics on the regular all the time, because they really care about their patients and they want to hear how we're serving them. So in the digital CM world, digital CM, it has potential, but I'm really interested to see how it pans out, who it's going to work for, and what SUDs it's going to be best fit for. And I don't think it's going to be that all substance use disorders are well suited for digital contingency management. Ultimately, our goal is across all of this work to move the field towards those who could benefit from contingency management, every person who could benefit from contingency management having access to it, and having access to it without having to use their own money to get it. We are not there, so I really hope that people will continue to work in this space. This is not anywhere near comprehensive, but a huge shout out to some of the team whose work I presented here today, whose papers I presented here today, to Fari, who is down here, who is amazingly beautiful. If you thought any of these slides were beautiful, it was all her, not me. And to the funders of this work, who we truly couldn't do it without. And that is it. Can we get out of here?
Yes, we'll have to stay on the mic.
Okay, I'll be right here.
Yeah, do we have any questions from the audience? And those who are streaming, send your questions in through the Q&A.
Thanks for a really great talk. Just an impressive body of work you have here. I'm just curious to hear you talk a little bit more about what it was, how you form relationships with the state and maintain them. It looks like you've done a lot of work with the state of Michigan. So yeah, just curious to hear how you've done that, how you pulled that off.
It is, I think it really, you have to just love having a lot of conversations, because that is what it is. It is 100% led by people saying like, oh, have you met this person? Let me introduce you, and having those conversations. And I find it to be, it makes me feel like the research is worth it, because it makes me feel that I am getting to actually do work that is impacting our community. But I think that at times when you get really busy and like you have a grant deadline and it feels really hard to like take 30 minutes to reach out and share about a podcast you did with your a state partner who runs the peer program, because you talk about peers or whatever that might be. Sometimes that can feel like it's not something that you just put forth some initial effort and then it pays dividends. It is something that you continuously spend time on. But it truly makes me feel like, or I'll say it in the opposite way, without the relationships within the community, I don't know that I see value in a lot of what I'm doing. And so the value for me is much more in making sure that we serve some of the patients at these clinics, for example, than in the paper that will come out of the work. And so I think it also serves as a real-time proof of concept of if, regardless of if we ultimately find like statistical significance of something, of if patients want to do something, which I think is just as important. I'm a big believer that we should not just build things and see if people come. We should build things with people and like make sure that there are things that people want to use. And this like sort of forces that point by doing it right with our clinics. And sometimes the relationships like don't go anywhere. There's lots of conversations that go absolutely nowhere. So again, it takes time, but it pays off a lot for me, at least.
Yeah, I just want to underscore Eli's question and the importance of your work. I think you are setting an example. I know I learned a lot just from this lecture about laying the groundwork and connecting with your community providers. It's pretty amazing. So, as are the data. I love the data, but that part of the work, both are important, but that part of the work is really groundbreaking, I think.
Thank you.
Other questions? Yeah.
Hi, thanks for your talk. As Eli and Steve were saying, it was a great presentation. I was just wondering, with the I2Q app, I was wondering what that process looked like to develop it, and like how long it took. Who did you have to collaborate with, and sort of the any details you might have about that. And also I was wondering, the personal messages that had some of those identity features, how did you create those? Did you have to work with certain groups to create those messages, or what did that process look like?
This is a big, I think this eats up more of my time than anything. So I first did not set out wanting to develop an app, which I think is important. We were partnering with a group called VCBH Health, which is actually out of Boston, that were providing digital contingency management. And I really enjoyed getting to know Jake, who was their CEO. I would have just run this through VCBH all along, but they got acquired by Optum. And at that point, we also had contracts with managed care orgs, but Optum decided to sunset the app. And so we just ended up, honestly, in a spot where it was like, we got to build it or we got to step away from this work. So that is why we built it, which there's a silver lining. We got to build something that we knew a product well, and we got to build something that we liked even more based on what we knew within our Michigan community. But originally I was like, I'm just going to use something out of the box. So much easier. Really recommend it when people can do that. Because building it was tough, and we were really only able to because we were able to work with a resource within the University of Michigan as part of our cancer center that does software development. So we worked with that team, and because Molina Health, which is one of our partners in this, were willing to be patient while we did a rebuild. And so we were very grateful for their commitment to our work. So that process took tons of iteration, and I can't underscore how much, even a app that seems perfect and professional has all sorts of issues, oftentimes on the back end data side. And this was the second app that I developed, another being fully in the adaptive intervention space that I didn't talk about today. And it is just incredible how complex it is to make a interactive, not super buggy app that works and that you can actually pull data from. So those are my lessons learned. That said, I'm very grateful we have it, but it I don't know that I would do it again. I say that now until I do it again. And then to the other piece, the identity was, so we started that as a pilot that we just sort of wanted to test out based on what we were hearing during our early work with our earliest work on incentives to quit was with federally qualified health centers in Michigan. I didn't present on that today. In working with them about things that was like the 30-ish, maybe 37 individuals that patients that were a part of that first project that they told us they wanted to see in the app, which was largely increased personalization. We always had the personalization based on whether or not you'd smoked or not, and the personalization based on baseline motives, but wanting to see it be tailored further. And so we started with, as we were going to be doing perinatal work, just wanting to tailor for people who are pregnant, because that felt like a natural place to go. And honestly, that then, like, once we had that aspect, it has, I don't know that snowballed is the right word, but there's lots of different identities. So it's just very much a work in progress. It's a work in progress that I'll say feels outside sometimes of an area that I like. I think there's a whole science there that we are just like scraping the surface of. Most recently, actually, on the Pecori Menthol project, one of our consultants, Dr. Yerger at UCSF, who's done incredible work in the anti-menthol space, pointed out to us that we needed to have a brand new motive around appearance. That appearance is a area that we never even had incorporated, like how tobacco smoke impacts your skin, your hair, not your physical health. And so I'm constantly learning ways that we need to better center this work around what people actually want to see in it. And so I would say they just feel humbled most of the time in that space. But it's a work in progress, which is beautiful in the QI world. We really can continue to grow it as we move.
Lara, unfortunately, we are out of time at this point. Thank you for a wonderful talk and for the amazing work you're doing.
Thank you guys so much for having me. This is my pleasure.